the first thing we are going to do is that we will evaluate a woman in labor, and then we will decide what are the monitoring tools in a partogram and what is basically the clinical utility of a partogram, because of which we are learning how to use it. So a partogram is basically a graphical representation of the progress of labor and also the maternal and fetal well-being. And in today's date, it is only plotted in the active phase of labor, which we state as 5 centimeters dilatation. Next. So the objectives of a partogram are that we have to detect the abnormal progress of labor. We are going to detect the CPD before the obstruction occurs. Then early detection of prolonged labor. Then timely decision whether we are going to augment, we are going to use oxytocin, or we are going to take up the patient for a cesarean section. Early detection of precipitate labor and also the maternal and fetal problems like fetal distress. And whenever there is a prolonged labor which stretches beyond 18 to 24 hours, there are chances of PPH and postpartum sepsis. So we need to avoid this also. So this is exactly why we are plotting this partogram. It's also being plotted to reduce the incidence of a cesarean section. Please change the slide. Please change the slide. So it is reducing the cesarean section, and when one doctor is leaving the duty and passing on the baton to somebody else, then at that time it facilitates a handover procedure. And it is important because it is a medico-legal document and your best legal defense when you are sued against by the patient in court. Next. So when we are the first thing we are going to do is take a clinical and obstetric history and do a general physical examination. Next. So we are going to do this per abdominal examination, which is the Leopold's maneuvers. In the first maneuver, we will see what is the height of the uterus. In the second, we will see which side is the back, which side are the limbs. In the third grip, which is the first polygrip, we will see what is the presenting part and whether it is being ballotable or not. And in the fourth, which is the second polygrip, we'll see how much of it has entered the pelvic brim. Next. So then we will see what is the lie of the fetus, whether it is longitudinal, it is oblique, or it is transverse. And in a longitudinal also, we are going to see whether it is cephalic or it is breech. Next. Then we will see what is the presentation, what is the part of the fetus which is occupying the lower uterine segment. Next. And we will also see the fetal attitude. So in case it is a cephalic presentation and it is a complete flexion, it is the vertex occiput which is going to present. Deflexed head, it is a sinciput. Partial extension, it is the brow, and complete extension, it is the face. I am giving all these details because these are what is going to be plotted on the partogram. Next. So then when we are looking into the descent of the head, it is a rule of 5. How many fingers are you are going to palpate the head above the pubic symphysis? So this is the rule of 5. And next. So a head that is mobile above the brim will accommodate the full width of 5 fingers. And as the head keeps on descending, the portion of the head remaining above the brim is represented by fewer fingers. Next, then we are going to do the fetal heart rate auscultation and then the PV examination. Next slide, please. We are going to do the PV examination next, in which we are going to see what is the dilatation and effacement of the cervix. Next. And we will also see whether the amniotic fluid can be seen, whether the membranes have ruptured or they have not ruptured. Next. And in case they have ruptured, what is the color of the amniotic fluid? Whether it is normal, that is slightly yellow. In case it is meconium stained, it is either green or brown, it is indicating fetal distress. In case it is yellowish green, it is post-mature. In golden, it is because of RH incompatibility. A dark colored may suggest a hemorrhage, and a dark brown can also indicate an intrauterine fetal death. Next. So we will reconfirm our per abdomen findings by a PV examination, that what is the presentation and position of the fetus. Next. and also palpate the anterior fontanel, the posterior fontanel, and the sagittal suture which is connecting the two. And we will feel the parietal bones on the two sides and then decide whether it is a posterior, transverse, or an anterior position. Next. Then the station of the presenting part will be seen in relation to the ischial spines. So how many centimeters above the ischial spine is the presenting part will determine whether it is -1, -2, -3 station, or when it is below the ischial spine, it will be considered as +1, +2, and +3. And 0 station is when the maximum diameter of the head, that is the biparietal diameter, has already crossed the pelvic inlet. And at that time, we say that the station of the head is 0. Next. And then we will assess the pelvis. Next. So the progress of labor will be continuously monitored, seeing that what is the cervical dilatation, effacement, and what is the descent and the station of the fetal head. Next. And the components of a partogram are that number 1, it is going to identify the demographic details of the mother. What is the fetal progress? What is the progress of labor? What are the maternal vitals? And what is the outcome of labor? Next. So, partogram will be done in all the pregnancies, but it is mandatory in a primigravida. Whenever, next please just fill in this slide. So whenever there's a high-risk pregnancy, malpositions are there like occipito-posterior, occipito-transverse, breech presentations. Whenever we feel that there's a borderline contracted pelvis, then you will see what is, and when you are giving the trial of labor. And next, please. And also in a vaginal birth after cesarean section. So the first curve which came up was a Friedman's curve, which came up in 1954. And this was a curve, next slide please. And this, please just fill in this slide. So this has got 2 phases, the first stage and the second stage. And the first stage starts with a closed cervix and ends at a full dilatation. Just go back please. And then we see that it is a slow latent phase and a very fast progressing active phase. And when the bearing down efforts start, we know that there is full dilatation and the second stage has started. Next. So basically the Friedman's curve is going to tell us, or it is going to give a graphic representation of the expected progress of labor in a woman. Next. And it also tells us that what is the normal rate of cervical dilatation and descent. And this was a gold standard initially, but now it has been used to devise the other partograms. Next. So then came the partogram with the latent phase. Next. Now in this partogram, if we see the latent phase is there, and this latent phase is there for 8 hours only. But we know that the latent phase in a nullipara can go up till 12 hours, and in a multipara, it can go up till 8 hours. And in case there's a protracted labor, this can even go up till 20 hours in a nullipara and 14 hours in a multipara. So because of this varied phase, this went into disrepute. And the concept of this alert and action line was given by Philpott and Castle in 1972. And this started after the latent phase. But because of this variable latent phase, this partogram was also removed. And then we come up to the WHO modified partogram. Next. Modified WHO partogram. Next. Which has an alert and an action line. And this partogram started only when in the active phase of labor, when the dilatation became 4 centimeters. We started this partogram at this stage, but there were a number of mistakes being made even in this partogram, because ideally the first plotting needs to be started from the alert level, but people were plotting it on the y-axis. Next. And it is also a decision-making aid when the abnormalities are detected, and many nursing homes and hospitals are still using this partogram without knowing that the new partogram is already there. Next. So this was the look of the modified WHO partograph. Next. And this consisted of the biodata, the fetal well-being, the progress of labor, medication, and the maternal well-being. Next. So the first thing which came up was to fill in the demographic details of the mother. Now, I just wanted to bring to your notice is that over here, the gravida and the para, both is being written, right? So once you are writing the gravida, it does not hold any importance because the parity is what is going to hold importance to see the progress of labor. How many times a patient has become paris? So either she is a nullipara or she is a multipara. So in the latest partogram, the gravida has been removed. Next. Next, please. Dr. Malti, please change the slide.
मैम मैं चेंज कर रही हूँ.
नहीं, इसके पहले भी एक स्लाइड थी. कोई बात नहीं है. So the fetal, next. The fetal well-being is recorded by the fetal heart rate, the amniotic fluid, and the molding. And the time axis is on the x-axis. And every block was half an hour. And this was being monitored every half an hour. But in fetal distress, it was being monitored more frequently. Then the cervical dilatation, next please. The cervical dilatation was being plotted as X and the descent of the head was being plotted as O. And if you see in this particular chart, the first marking is always on the alert line. And when it moves on the alert line or it moves on the left of the alert line, it is considered normal. But when it moves in between the alert and the action line, it states that there is a protracted labor and this needs to be corrected. So you will either do an ARM in case the membranes have not ruptured, or you will go ahead and give oxytocin, or in case your nursing home or hospital is not equipped to deal with obstetric emergencies, in that case, you will transfer the patient to a tertiary care center. And when this graph goes beyond the action line, this is a time for delivering. Next. So you start plotting when the dilatation is 4 centimeters, and when the graph is moving on the alert line, it is an indication that the dilatation is taking place at 1 centimeter per hour, which in today's date we see does not happen, and it is individual. Every individual has a different rate of cervical dilatation. And in this, what used to happen that the minute the graph went on the alert or action line, people used to take the patient in for a cesarean section. So that used to be a big problem because we see that even when the graph has gone beyond the action line, a number of patients used to deliver vaginally absolutely normally. So this is why this concept was also removed in the new partogram. Next, please. And the action line was 4 hours away from the alert line, indicating that you had a time period of 4 hours to decide which side the plot was going. Next. And then the descent of the head was plotted as rule of 5, we've already discussed. And next. Next. Now, here the contractions were given a diagrammatic representation. Now, 1 square is equal to 1 contraction. And we had to plot the number of uterine contractions in 10 minutes. So in case there were 3 contractions, 3 boxes were colored. In case there were 5 contractions, 5 boxes were colored. And the duration was measured in seconds from the time the contraction sets in to the time the contraction passes off. So when the contraction lasted for less than 20 seconds, it was considered as weak and it was plotted as dots. When it was between 20 and 40 seconds, it was considered to be moderate and it was plotted as slanting lines. And when it was strong, it was plotted as it was completely shaded. Next. And then the medication was, if oxytocin was given, it was recorded. Any other drugs, IV fluids, antibiotics were also recorded. Next. Then the maternal well-being was recorded every half an hour. The fetal heart rate was recorded. The BP was recorded in the form of arrows every 4 hours. And earlier, in case it was a case of preeclampsia or chronic hypertension or eclampsia, then the temperature was also recorded beneath the fetal heart rate and the blood pressure. And next slide. And the urine protein and acetone was also recorded, and the volume also recorded as and when it was passed. So now even this particular partogram is obsolete. I discussed it because a number of partograms have been attached in court, or your old files have these partograms, so you can just go ahead and check whether you have plotted it correctly. Now we come over to the latest partogram, which was introduced in December 2020, but because of the COVID times, people did not come to know about it. Next slide, please. And in this particular WHO Next Generation Partograph, which is also called as the Labor Care Guide, only 3 words were very, very important. And this said that it needs to be a positive childbirth experience for the mother. Next. So in this, what happened was that there was an over-medicalization of childbirth processes. The minute patient comes into the hospital, you say, iski IV drip laga do. And patient supine position mein aa jayegi. Then another thing is give oxytocin so that the whole process gets speeded. So this tends to undermine the woman's own capability to give birth, because this giving birth is a very natural process. And this used to negatively impact the childbirth experience. Next. So this is why this was revised, and this WHO Labor Care Guide is a transformative tool designed to enhance the maternal and fetal outcomes, because number 1, it is evidence-based, and number 2, it gives respectful care during childbirth. Next. So what were the reasons for revision? Number 1, again, increased incidence of cesarean section, over-medicalization of childbirth. Then a debate on what is normal progress. Now we know that the labor does not move according to 1 centimeter per hour. So it needs to be individualized for every patient. And then also questioning the alert and the action line. How slow is this slow labor? So this was a very big question which was coming up. Next. So this is a snapshot of the labor care guide, which I hope everybody has got a printout, because it is going to be easier to understand once you have the printout in front of you. Next. So the first thing is that labor and childbirth should be individualized and woman-centered. So gone are the times of paternalism, when the doctor would decide, okay, fine, हमने ARM कर दिया, हमने oxytocin लगा दिया, या we are taking the patient, हमने forceps लगा दिया. No, nowadays it needs to be assessed, and the plan of action is to be discussed with the patient. So it has now become woman-centered. And no intervention will be done without a clear medical indication. Then whatever intervention will be done needs to be beneficial for the patient, and the golden words that it has to be a positive childbirth experience for the mother, the newborn, and her family. Next. So, no, let's go back. So this is these are the essential physical resources. So first is a respectful labor and childbirth care. Then there has to be some companion with the patient who is giving emotional support. The staff needs to be very, very courteous. Now, pain relief strategies, which we would usually never offer to the patient, has become mandatory. Regular labor monitoring, documentation of events, audits, and feedback needs to be done. Oral fluids and food intake is being encouraged in case the patient is moving on the normal side. And this is because in such a situation, the patient is going to be mobile. Then mobility in labor and birth position of choice. There needs to be a pre-established referral plan in case you need to transfer the patient from one center to the other, and also the continuity of care when 2 doctors are changing hands or changing their duties. Next. So there are three W's of the labor care guide. For whom is it required, when is it required, and where is it required? Next. So number 1, it is used for all pregnant women regardless of their risk status. Next. This partogram was devised for low-risk pregnancies, but now it is being used for all the laboring patients. Next. It will be used when the dilatation becomes 5 centimeters and not 4 centimeters as it was previously. Next. And where should it be used? It should be used at all levels of healthcare facilities, although the plan of action will vary depending upon the level of care. Next. So the similarities between the WHO partogram and the WHO labor care guide is that in this also the progress of labor and the descent of labor is going to be plotted, and the well-being of the woman and the baby is going to be written. Next. Now we will see what are the changes which have come up. So number one, we know that the labor is not going to progress at 1 centimeter per hour. So the alert and the action lines have been removed. And they have been replaced with evidence-based time limits at each centimeter of cervical dilatation. That if the patient is 5 centimeters and 6 hours have passed and the patient has not progressed, it is an alert. Or she's at 6 centimeters and 5 hours have passed, it is an alert. The second thing is the dilatation we have already discussed is to be 5 centimeters and not 4 centimeters when you start plotting this graph. And this particular partogram also has a monitoring of the second stage of labor, which was not there in the initial partogram. Next. So supportive interventions have been brought in. The strength of the uterine contractions, that whether it is mild, moderate or severe, has been removed because it is very, very difficult to quantify and standardize it. And whenever we see that there is any kind of a deviation from the threshold, we need to encircle it and highlight it. Next. So let us see the parts of the labor care guide. The first is identifying the woman. The second is the supportive care. The third is the care of the baby. Fourth is the care of the woman. Fifth is the labor progress. Sixth is the medication. And the seventh is a shared decision making. Next. Please go ahead one by one, just one by one, please. Just go back to assess. So we see the first line, and this is what you need to assess in this particular labor care guide. It has been given in a row what you need to evaluate. The second, next. The second area has been given that there is a chart to document the labor observations. The third, when you see next, we see that on top, if you see, it has written alert, where the active first stage is written, it is written alert. And that is a threshold of labor observations where we need to get alerted. I will discuss each and every part. So, and the fourth area is that whenever we see an alert or we don't see an alert, we have to assess, we have to speak to the patient and the relatives and then decide the plan of action. Next. So this is the plan of action. Next. So the labor care guide needs to be plotted only once the dilatation is 5 centimeters. Next. Please go one by one now. So the first thing which is going to be plotted is the name. Please keep on clicking. Yeah. The next we are going to see is the parity of the patient. Over here, the gravida has been removed, but the parity is still there. Then the labor onset, whether it is spontaneous or induced, this also needs to be written in it. Just click, please. Then the active labor diagnosis. Please, next, just click on it. Labor onset is spontaneous. Then the active labor diagnosis will be written, the date will be written. Then whether the membranes have ruptured or not will be written. And in case you do not know, you will write a U. Just please click the U. And then we come over to the risk factors. Next. So any history of any risk factors, whether past or present pregnancy, will be written. For example, any history of abortion or childbirth or stillbirth or a preterm labor, diabetes mellitus, chronic hypertension, preeclampsia, whether the patient is an elderly primary or an adolescent pregnancy, all this will be noted in the risk factors. Next. So the second part, if you see, is the supportive care. Now understand that there is a first part which is the active first stage, and there is a second stage plotting also, which has been given a time period of 3 hours. And next. Okay, so first we will discuss this time. So the time has been given as you can write it as 6, 7, 8, 9, 10, 11, 12, 13, 14, or which is a 24-hour format, or you can give it a 12-hour format, which is basically a you will write it as AM or PM. Just keep on clicking, please. And the second part is the hours. This hours is going to identify the number of hours that have elapsed during the course of labor. So when the patient comes at 5 centimeters, how many hours have elapsed since the patient went in active labor needs to be written in this. And each column represents 1 clock hour. Please just click this and go on to the next slide. Please continue clicking because it's going to fill in the blocks. Yeah. Okay. Now, please next. So in this chart, please understand that, see, this is a first stage plotting and the second stage plotting. So the patient went into active labor at 6:30 and by 12:30, the full dilatation was there. So the first stage of labor got completed. So the first stage of labor gets completed when the full dilatation is there. So then this graph jumps onto the second stage of labor, and then you start plotting in the second stage of labor. But in case 12 hours have elapsed and still the patient is not fully dilated, then you will add another labor care guide. Next. Next slide, please. Okay, so now we have the alert column. If you see on your partograms, you will see that there's an alert column. Now, this alert column is going to give you the threshold for abnormal labor observations that require further assessment and action. And whenever we have a finding which is in the alert column, you will always encircle it either with another pen, a red colored pen, so that it is eye-catching. Next. Now we will go one by one. Yeah, please just go ahead with this. So, companion. Now, if you see the alert, the first part of supportive care is the companion. Alert is N, that if you have not given her a companion, this is an abnormal thing. So it is an alert. In case you have not offered her pain relief, this is an alert. In case oral fluids have not been given, this is an alert. And posture, if is supine, this is an alert because you want the patient to be mobile as much as possible. And if we see that all this is going to be plotted in the second stage of labor also. So this area was not there in the previous partogram. Next, please. Okay, so now we will take this one by one. Companion, next, please. Okay, so Y is yes, N is no, and D is denial. So in case the patient, in case you have written a N, click please. In case you have written an N, then this is an alert if you have not offered a companion. So this next, click please. So this will be encircled because this is an alert. So this will be encircled. So in case you have written a no, you will offer to give her a companion. You will, and in case you have written a Y or a yes or a D or a denial, then you will encourage the patient to choose a companion of her choice throughout the labor. Next. The next is the pain relief. You can offer a pharmacological or a non-pharmacological means of pain relief. So it can be either epidural analgesia, or in non-pharmacological, you can give her breathing exercises, muscle relaxing techniques, acupuncture, acupressure, aromatherapy, whatever the patient wants, or a massage. So all these factors will be offered. So again, Y is a yes, N is a no, D is a deny. Please click. So in case you are giving, you are writing an N, this will again be encircled because this is an alert. Next. So oral fluids will again, Y is a yes, N is a no, D is a deny. Click please. So in case you have written Y, it means that you are giving, and because it is not an alert, this will not be encircled. And this will be given in the form of juices. Please click. juices, and then ice chips or water, and a light diet is also going to be encouraged. Next. Light diet will also be given. Then we come over to the posture. SP is supine and MO is mobile. So whenever you want the patient to be in a mobile position as much as possible, and in case the patient comes in a supine position, this is an alert. Please click. And in case the patient is supine, you will offer her either a left lateral position, or it can be a kneeling position or a squatting position. Please click. It can be a kneeling position or a squatting position. And in case, next please. So in case it is a supine position, and again it is an alert, so you will encircle this. Next. So by the end of this section, you will see in this particular graph that at 6 hours, there was no companion, no pain relief, oral fluids were given, and the patient was mobile. But in the next hour, we have rectified it. We have given her a companion. We have given her pain relief. We are giving her oral fluids, but the patient has come in a supine position. So that is an alert. Next. The next section is the care of the baby. In this, if we see, there is a baseline fetal heart rate and a fetal heart rate deceleration. These two things will be assessed per abdominally. And the other four, that is the amniotic fluid, the fetal position, the caput, and the molding, this is going to be assessed per vaginally, so will be plotted every 4 hours. Now, if we see this baseline fetal heart rate, we see that the 1 hour time period has also been divided into half. So your basal fetal heart rate and the fetal heart rate deceleration will be plotted every half an hour in the first stage. And in the second stage, it will be plotted every 5 minutes. But the most significant value will be written in the 15-minute column of the second stage. So this whole section will be plotted throughout the first phase and the second stage. Next. So we will take this one by one. The baseline fetal heart rate, if less than 120 or more than or equal to 160, is significant. Next, please. And in case it is the fetal heart rate recording will be done for full 1 minute, starting from the contraction and also continuing for 30 minutes beyond the contraction. Please click. And in this also record every 5 minutes in the second stage. And next. The most important is that CTG is not recommended by WHO. It is an intermittent auscultation, which has been advised by the WHO. Next. So we will fill in the parameters like this. Next. Next. And now next. So the fetal heart rate decelerations. N is for no decelerations, E is for early, L is for late, and V is for variable. So early decelerations we see basically in fetal head compressions. Late is a variable we see in cord compressions. And late is the most ominous one, which is usually due to any uteroplacental insufficiency, or it is because of fetal hypoxia, fetal acidosis. So this L is an alert. So if we are writing L, we will encircle it. Next, please. Next, please. So you will encircle it because L is an alert. Next. So then we come over to the amniotic fluid. The first thing we see is whether the membranes are intact or they are ruptured. So in case they are intact, we will write I. Please click. And this, because this is not an alert, we will not encircle it. Please click. Please, yeah. So, and then C is for clear lacquer. M is meconium stained. And meconium stained also has three. 1 plus is thinly stained, 2 plus is moderately stained, and 3 plus is thick meconium. So it is the 3 plus meconium which is an alert. And the blood staining, which will be written as B, is also an alert. Please click. So in case we find a blood stained amniotic fluid, please continue clicking. So our antenna should go up, whether it is an abruptio placentae, or it's a placenta previa, or a vasa previa, or it may also be a uterine rupture. So this will be known in case you see a blood stain discharge. Next. Then we come over to the fetal position. Any posterior or transverse position is an alert and will be considered as an abnormal fetal position. And if it does not convert to occipito anterior or an anterior position, this is not a very comfortable story. So whenever it is P or T, this is an alert, but A is absolutely fine. So please click. And because this is not an alert, we will not encircle it. Then the next finding is that of caput, which is a diffuse swelling. Please click. This is a diffuse swelling of the scalp. Click. 0 is no caput, 1 plus is mild, 2 plus is moderate, and 3 plus is marked caput. And it is the 3 plus which is very, very important and is an alert. Next. Now coming on to the molding. Now, we have already discussed that we need to feel the anterior fontanelle, the posterior fontanelle, and feel the sagittal suture. And in case the parietal bones are separate, it is stage 0. In case they are opposed, it is +1. In case they are overlapping, but you can reduce it with a gentle push with the finger, it is +2. But in case it is not reducible, it is +3. So it is the +3 which is an alert. We see that +3 has been given as an alert. So until and unless that is there, that is not a problem. The per vaginum examination will be done every 4 hours. And in case we are doing it earlier, then we need to be careful. Please go back one slide. No. Yeah. So by the end of this particular part, we see that the liquor is clear. The fetal position is occipito-posterior and there is no caput and no molding in this particular case. Next. Then we come over to the care of the woman, which involves the pulse, the systolic, diastolic blood pressure, the temperature, and the urine. Next. So the pulse, if less than 60, more than or equal to 120, it is significant. Next. So in case it is a maternal bradycardia, we will see whether some specific medications like digoxin or calcium channel blockers or any kind of a beta blocker has been given. Or if the patient is in supine position, there's a lot of pain or bleeding, or there's some cardiac disease. And in case, please click, in case there's a tachycardia, we have to look into whether there's any dehydration, pain, fever, any signs of bleeding or any signs of shock. Next. Then the systolic blood pressure, if less than 80 or more than 140, and a diastolic blood pressure of more than 90 is very, very significant. Please click. Again, click. So whenever there is a low blood pressure, please click. It can either be a hemorrhagic shock or a septic shock. Please continue clicking, please. Or it can be an occult or frank hemorrhage. And a high blood pressure will be seen in cases of hypertension. Next. So then the temperature will also be recorded. And finally is the urine recording. Next. Which in case it is negative will be written as -/-. Please next. Yeah. So whenever there is a negative finding, please click again. We see that how this minus has been written. T is for trace, 1 plus, 2 plus, 3 plus, and 4 plus is again written. So whenever there is a proteinuria, next please. Your antennas will go up for any preeclampsia, UTI, severe anemia, or renal or cardiac diseases. And in case of ketonuria, it may be an undiagnosed diabetes, or there may be a dehydration because of some vomiting or diarrhea, and even in cases of prolonged labor. Next. So by the end of this section, please go back. So by the end of this section, we see that the labor is progressing. You are recording all these findings of the woman every 4 hours. And now the occipito-posterior situation is also converted into occipito-transverse, right? So next slide. Now we come over to the labor progress, which is one of the most essential parts of this partogram. And if you see in this, the contractions every 10 minutes has to be recorded every half an hour. and along with the duration of contractions, which has to be recorded every half an hour. And in the second stage, this is to be continued, and this will be written every 15 minutes, though it is to be recorded every 5 minutes. Right? Then we come over to the cervical dilatation. Now, cervical dilatation, in case the patient is at 5 centimeters for more than or equal to 6 hours, 6 centimeters for more than 5 hours, 7 for more than 3 hours, 8 for more than 2.5 hours, and 9 for more than 2 hours, this is an alert. And you will have to consider that this is protracted labor, and you will have to decide what to do next. Now, because the full dilatation gets completed in the active first stage, so there is nothing to plot on the in the second stage. So the second stage does not have any area of plotting the dilatation because the dilatation is already completed in the first stage. But there's a small column which has been given, which is for writing P when the patient starts pushing. So I will explain this further on. And then the descent of the head will also be written on this particular part. But this can continue in the second stage of labor because complete descent may or may not occur in the first stage. And this may continue in the second stage. So the plotting area has been given even in the second stage of labor. Next. So coming on to this contraction. So at 6, we see that 3 contractions for 30 minutes. Next half an hour, we see that there are 4 contractions in 40 minutes. So whenever there is a contraction which is more than 5, please click. So whenever there are more than 5 contractions in 10 minutes, this is a tachysystole. And whenever there's a contraction which is lasting more than 60 seconds, it is a hypertonus situation. Next. Now, whenever the contractions are less than 2 in 10 minutes or they are lasting for less than 20 seconds, it is an inadequate uterine activity. Next. So whenever there are continuous contractions, this is a sign of obstructed labor, and again your antennas need to go up. Next. Coming over to the cervical plotting, please just click 3-4 times so that we get the X on the cervix. Please click. Please click. Yeah. So over here we see that this you will start plotting this partogram only once the dilatation is 5 centimeters. The descent will be plotted by the rule of 5. And next, please click. And this will be plotted in the same timeline as that of the cervical dilatation, because you have done a PV and you are plotting the cervical dilatation. At that same time, you will write what is going to be the descent of the head. Next. So by the end of this column, if you notice, I don't have a pointer, and because somebody else is projecting, I can't pinpoint. But if you see in this, at 6 a.m., the dilatation is at 5 centimeters. 4 hours later, the dilatation is 8 centimeters. And another 2 hours later, the dilatation is completed. So now this and above in the care of the baby, we see that the occipito-posterior position has changed over to transverse and then to anterior. Then in the second stage, we see that in the same column as the dilatation, we see that there is a P written over there, which is indicative that the patient has started pushing. So P is written when the patient starts pushing. But the descent has still continued in the second stage of labor. It becomes 0 by 5 in the second stage of labor. Next. Then we come to the medication. Next. Please just go on clicking. So oxytocin, if given, it will be plotted. If not, no. Please go back. Medicine, name of the dose, name of the drug, dose and route of administration will be written. IV fluids will be written. And if it is not being given, then you will write an N. Next. And this is a shared decision making, which is the most important part of this partogram, that whatever your findings are, please just continue clicking, that you will always assess whether you need a companion. Please click, please change over again. Companion to be arranged, pain relief to be given, arrange for a companion. In case there is normal progress, you will write continue monitoring. So the plan, you will write whether to continue monitoring or to give some kind of a diagnostic test, or you want to do an ARM, or you want to give oxytocin, or you want to do an assisted birth with vacuum or forceps, or you want to take the patient in for a cesarean section. Please click. So this is very, very important, and you need to explain this to the patient in a language that she understands. Next. And also give explanations of the procedures. Next. And also the findings of the physical examination should be explained to the woman in a companion and a decision taken after with her assent. Next. Then finally, the initials of the doctor is mandatory. Next. Now, just a few words about the second stage of labor. This is a time period of 3 hours has been given, because normally we say that the second stage of labor for a multi-para is 30 minutes and for a nulli-para it's 1 hour. And in case it is a protracted labor, you can double this, you can make it 1 and 2 hours. So 3 hours has been given as a maximum time period for the second stage of labor, beyond which if it is going, then you will have to take some kind of an action. Please continue clicking. So in this, if you see, it will start whenever the full dilatation has occurred. And then in this, the patient has an urge to strain or push. Next. So you will see this graph. You will continue plotting. Next. I've just given an example. Next. Yeah, now just click in this. So you see that at 5 a.m., the contractions number, and see now the patient has started pushing. PP is being written. And then finally at around 7 a.m., between 6 and 7 a.m., she has given birth. Next. So the outcome of labor will also be jotted in this. Please just continue clicking. It's just to show how it is supposed to be plotted. Please click. Normal progress, normal progress. Please click. Please continue clicking. Continue monitoring, and this is, no, just go back. Next. Next. So this is the look of a completed plotted partogram. So this is how your partogram is going to look like once you have finished plotting this partogram. Next. Now, when the fetal membranes rupture, a per vaginum examination should always be done, because there may be cord prolapse, cord compression, or abruptio placentae when the amniotic fluid suddenly gushes out. Next. Next. This is a very important slide, because this states that there is no role of augmentation of labor if the latent and the active phase progress is normal. Next. Please click. Okay, so this is plotted so as to give a continuity of care, and it is a graphical record which with just one look will show the progress of the laboring woman. Next. Please. So next. So it is an important clinical record. Now we come over to the medico-legal part, that it is a standard obstetric practice. Next. Just click the full slide. Okay. So negligence claims will arise in case the partogram has not been plotted properly, or it has been plotted incorrectly, or there are findings which are abnormal in it, but you have not taken action. Right? So all these things are going to call in for a suit of medical negligence. Next. So properly documenting all the observations on the partograph is crucial, and this documentation provides a clear timeline of labor progress and can be used to support or refute claims of negligence. Next. Now, you need to know how to interpret the partograph. What is the alert line? What are the values that need to be allotted, that need to be evaluated, and how are you going to discuss it with the patient? Next. And failure to recognize or act on these indicators can lead to adverse outcomes and legal repercussions. Next. So the partograph enables early intervention in labor. Next, either it can be because of augmentation by giving oxytocin or doing an ARM, or even taking up the patient for a cesarean section. Next. So it will also be used for transferring the patient to another hospital in case your place is not equipped to handle obstetric emergencies. Next. So the medico-legal aspect is that it's a critical tool in obstetric care that can have significant legal implications if not used correctly. Next. So a properly used partograph will identify the problem, but in case you have not used it and failure to use it will bring in complications and malpractice claims. Next. So the legal challenges, let us come on to that. Next. So the first is that it is a crucial evidence in the legal proceedings. Next. And you will demonstrate the kind of care provided. You've given supportive care, you've given pain relief, and then what kind of a decision you have taken and why you have taken it. So the rationale for the interventions taken is also evident on the partogram. Next. So if the partogram shows adherence to the standard guidelines and the standard operating protocols, it can help establish that reasonable care was provided, mitigating the potential claims of negligence. Next. So in this, you can reconstruct the events that initially it was occipito-posterior, then it changed to occipito-transverse, then it became occipito-anterior. So you can reconstruct the events of labor and delivery. And it also provides a timeline of key events and decisions which can be crucial in resolving disputes. Next. So the claims of negligence, we have already discussed that in case the partogram indicates that the labor progress deviated significantly from the expected pattern and still you did not go ahead with any timely intervention. Next. Next. So the key considerations are, please click, that it has to be an accurate documentation. Regular updates of the newer partograms needs to be there, and there needs to be a clear documentation. So in next 2 minutes, I'll just take one case because of the paucity of time. Next, please. So this was a case of Master Vatsal Aniket Verma versus Gupta Nursing Home, where the patient, please click, the patient was a primi gravida and she went over for an antenatal checkup. Next. So here, next. She was assured that everything was fine and she would have an absolutely normal delivery. And just 5 days prior to her date of delivery, an ultrasound was done, which next please, which indicated that the baby weight was 3.5 kg. Next. So the patient got admitted in labor. Next. Please click this slide. So even though the patient was unable to bear the prolonged and difficult labor pains, she said that she asked for a cesarean, but the request was not heeded. And a male baby was delivered with forceps. No pediatrician or anesthetist was available. And the father of the child noticed that the right hand of the baby was absolutely limp and senseless. And the pediatrician later diagnosed it as Erb's palsy. Next. So the allegations were that there was lack of facility for cesarean operation. There was no pediatrician or anesthetist available during the delivery. Next. Did not call any pediatrician to examine the child. Next. Please click this slide. The patient was discharged on the same day without any discharge slip, and Erb's palsy was because forceps had been put by the doctor. Next. The allegations were also that the complainant had to go ahead to several neurologists, got a reconstructive surgery done in Houston at 22 months of age of the baby, but still there was no cure. So the patient went ahead and sued a malpractice claim for 65 lakhs. Next. So the defense said that all the signs were favorable for a normal delivery. The head was engaged, which is very, very good for a primary. The weight of the fetus was also 3.5 kg, which is not an indication to call in for a cesarean section. Next. The patient was not willing for a cesarean, wanted a normal delivery. The delivery was performed with utmost care, caution, and skill, and there was no negligence on the part of the doctors. Next. The defense also said that the hospital had full infrastructure to tackle the emergency cesarean. The anesthetists were on a roll call and would have landed up in 10 to 15 minutes in case they were required. And it was not a case of shoulder dystocia. The partogram was also attached as documentary evidence, and there was no negligence on the part of the OP. And they prayed for dismissal of complaint. Next. So the judgment said, when the court, when they were discussing the case, they said that the partogram and the delivery notes clearly mentioned that it was because of maternal exhaustion that the forceps had been put. And the shoulder was delivered spontaneously. There was no case of shoulder dystocia. And they also said that the complainant failed to prove the negligence on the part of the doctor. Next. The doctor was fully skilled and had adequate knowledge. And expert opinion was taken by the clinicians from All India Institute, who said that the doctor cannot be held guilty of negligence by any stretch of imagination. So therefore, the complaint was dismissed. So here, partogram was a very, very, very important tool. Next. So a well-documented and accurately interpreted partograph can be a strong defense in a malpractice claim, while a poorly documented or misinterpreted one can undermine the defense. Next. Next. So to conclude, if you fill the partogram correctly, you will be able to detect abnormal labor very early and take action. Always counter-check whether you have filled the partogram correctly, as it is a very, very important medico-legal document and your best legal defense. Next. So Vedic literature lauds doctors as Vedyo Narayana Harihi, but gone is the time when doctors were considered gods. Next. So this is the way the morning of a doctor looks like. Next. But you are basically hit with the paperwork. Next. So the doctor says, if I don't look at the paperwork, it will just go away. Next. But remember not to shirk the paperwork, because next, no job is finished until the paperwork is done. Next. These are the references. Next. Wishing you all a litigation-free practice. Thank you very much. Next. Thank you very much for the patient hearing.